Good morning, good afternoon, and welcome to the I Save That webinar series. I'm Judy Thompson, the Director of Clinical Education for AVA, and we welcome you to today's program. Let me get the slides going a little bit for you. So today, our program is What's New in the Fight Against Catheter-Related Bloodstream Infection. This is our speaker's bio. It will be in the handout section for you. If you've been on waiting for a little bit, you've been able to read this. I'm not going to read it to you. So if you want to know more about Chris, I'm going to be doing a little intro for her as we finish up the intro to the program today.
Good afternoon, everyone. How's everybody doing? Thank you so much for taking some time out of your very busy day to spend some time with me and learn about the very important new techniques. Some may be new to you, some may not be, in preventing CRBSI. To start with any good CE program, we have some disclosures. First of all, I am an employee of RIMED Technologies. I'm the clinical education manager for them. And I also own some stock in Teleflex. We are not going to be talking about any type of off-label use in this particular presentation. We also have some objectives, like any good CE program. First, we're going to talk about the current rates of CRBSI in U.S. hospitals. And by current, I'm going to be speaking specifically of 2018 numbers today. That is as current as has been reported so far. We're going to discuss some very common strategies for preventing CRBSI, things that we've been doing maybe for years, and some new technologies, new ideas, new methods to reduce the risk of CRBSI. And jumping right in, we're going to have a poll question for you as well. Judy?
What is your work setting? One of the following: hospital, home infusion, outpatient, or long-term agency or other?
Yeah, I put this question out there to start with because I really want to get an idea of who our audience is today, what type of setting you guys work in, and maybe I can tweak some of the information here more specific to your setting.
Well, the results are 78% are in the hospital, 2% home infusion, 16% in long-term, and 4% in outpatient infusion.
Well, that's fantastic. It's very exciting to see people from across different modalities and locations joining us today and all across the United States. And so I'm really thrilled that you're all able to be with us. First, I guess the biggest question asked is, do you guys still think CRBSI is still a problem? If you look at the Joint Commission website or the CDC website, they're not so focused on it anymore. In fact, the information that they have in their arsenal, they both have toolboxes listed with ideas and publications on fighting CRBSI, but nothing is more recent than 2013, 2014. So for the last 5 years, they really haven't posted anything new. They do update the reported amounts, rates of CRBSI, but in 2015, we stopped the way we reported as a percentage and started reporting as SIR. And I'll go into that a little bit as well. But some just general information. I know that right now, everybody is very focused on COVID-19 and that COVID-19 prevention and COVID-19 treatment are really taking up the majority of bandwidth in hospitals, so to speak. And that's certainly understandable. But let's not forget that CLABSI is still a problem. About 30,000 people every year still get a CRBSI in the United States. And costs are still running anywhere from $40,000 to $100,000 to treat one infection. In fact, hospital-acquired infections still are a problem. The CDC stated that on any given day, 1 in 31 hospitalized patients will still get a hospital-acquired infection. 1 out of every 31 didn't come into the hospital with an infection, but will be treated for one while they're there. Now that includes all infections, including surgical site infections, ventilator-acquired pneumonia, things of that nature. But let's think about CLABSI specifically. The mortality for CLABSI still remains at 12 to 25%, despite our best actions and activities. 1 out of every 4 people that get a CRBSI are going to die from it. And I'm sure you feel like I do, but that is just not okay. We need to do something about that. Still, approximately 723,000 people every year get a hospital-acquired infection. And out of those 728,000, about 99,000 of them will die from that hospital-acquired infection. That's way more deaths than we're willing to sacrifice. And that's not even mentioning the costs. A couple of interesting things that have happened regarding the CLABSI reporting or CRBSI reporting. I'm going to use those terms interchangeably during our presentation today. Acute care facilities have not had to report CLABSI numbers from March 15th through June 30th of this year. And that date may be pushed even further out. That's the mandate from CMS, the Centers for Medicare and Medicaid. They basically said that because of the COVID-19 pandemic, that we don't have to report our CLABSI numbers because they're not going to use them to calculate any penalties or reimbursement. Now, that doesn't mean that NHSN won't still collect your data. They certainly will if you are going to report it. But what it does is take the pressure off of the infection preventionists to have to collect the CLABSI data every day when they're focusing on the pandemic instead. Now, a lot of other people that are involved in CLABSI prevention have asked me, what defines a CLABSI? What exactly gets reported to the National Hospital Network? What exactly should we be worried about? And so I want to clarify some of the terms that are used by NHSN to collect data. A central line to them is any intravascular catheter that terminates at or close to the heart or in one of the great vessels and is used for infusion, withdrawal of blood, or hemodynamic monitoring. These catheters have got to be in use for at least 2 consecutive days, calendar days. Day 1 is the first day of insertion or access. So, for example, any internal jugular catheter is a central line. But there are some devices that you might consider central lines in your hospital or treat them like central lines, but they're not considered central lines for the reporting purposes. And these are some examples of things that are not considered reportable central lines. Things like midlines, peripheral IVs, of course, but ventricular assist devices, ECMO devices, AV fistulas, grafts, arterial catheters. It's important to note, though, however, umbilical catheters, all umbilical catheters are considered central lines. So these are NHSN definitions. Honestly, it's getting more difficult to find the reported numbers for hospitals because of the way things are reported now. In 2015, the NHSN decided to kind of find a way to even the playing field. So they created a formula called a standardized infection ratio. And they take the raw numbers that are reported, the number of catheters in use, the number of infections, and put those into a formula that takes into account things like the type of hospital that you are in. Is it a community hospital? Is it a teaching hospital? Is it a very large hospital? Is it a small hospital? And so they tried to level the playing field that way by using this ratio. So now reporting is done by standardized infection ratio. And in 2015, the standardized infection ratio of 1 became the baseline. So everyone that had an SIR higher than 1 was doing worse than the baseline, lower than 1 was doing better than the baseline. However, the standardized infection ratio has gone down as a baseline every year since then. This is a map of the United States, and the darker the color of your state, the higher your standardized infection ratio is in your state overall. So the darkest colored states, they're at anywhere between 76 and 0.76 and 0.97. We don't have anyone higher than 0.97 at this point, which is great. So overall, things are definitely improving. Judy, we're at the South Pole. Time for another poll.
Perfect. Are you members of a CRBSI prevention committee? Yes, no, or your facility does not have one. All righty, we're going to close this poll and I'll show you the results. 34% of you on this are, 54 not, and 12% do not have one, Chris.
One reason that I ask is because there are some great resources available to hospitals. One, this is specifically from the Joint Commission. They actually have a CRBSI toolkit. Like I said, some of the information out there is actually outdated because they haven't updated their toolkit since 2013. But a lot of the basics still apply, and there are some excellent ideas that you can use and suggest to your hospital in case they're not following all of these great ideas and using all these great tools. Another great resource for CRBSI prevention is the CDC. Their website has some excellent tools as well. They, again, haven't really been updated since probably about 2013 or 2014 as far as the toolkit goes, but the basics are there, and there's some great resources there as well for you. So you might be interested to know, although CRBSIs are declining and the standardized infection ratio has gone down nationally, what exactly are we worrying about? What germs should we be nervous about? Well, this is a report from the NHSN data collected as of 2017, and it still shows MRSA as number 1. Your first column is the hospital wards, non-ICU departments, and then the second column are your hospital ICUs. They still break them out in those two categories. So Staph aureus is still our number 1 biggest enemy when it comes to CRBSI outside of the ICU, but inside the ICU, we're more worried about Staph epi, coag negative staph, which is Staph epi. That is still number 1. And you're looking at about 13% of all infections versus Staph aureus outside the hospital outside the ICU is about 15%. What is really concerning, though, is number 2 in the ICU is Candida albicans. That's still 10% of all central line infections. Why is Candida such a concern in the ICU? It's because of its mortality rate. It has a much higher mortality rate than a lot of the other bacteria or germs that attack our lines. The mortality rate for Candida, it can be up as high as 28%. Candida albicans is by far the leading type of Candida infection that you'll see in the ICU. Some of these other ones can be very difficult to treat. They're drug resistant, but Candida albicans out of all the Candida species is about 37%. A particularly concerning type of infection that we're seeing in the ICUs now outside of the COVID world is Candida oris. This is a very scary germ because this fungal infection has a 33% mortality rate, guys. That's right. 1 in every 3 people that get Candida auris will die from it. It's extremely difficult to identify because it mimics a lot of the other Candida species. And it's also multi-drug resistant. So the things that we typically use to treat Candida albicans and other Candida illnesses will not work with Candida auris. It's very frightening because it was first identified very recently, only in 2009 in Asia, and traveled very quickly over here to the United States. As of May of this year, we have 1,122 cases nationally. And New York and Illinois are the hotbeds. And New York has almost 500 cases. That's not really surprising considering how many people come into the United States from international destinations through New York. That's likely how it's spread. But it's something that we all have to be aware of because every month there are more and more states that report Candida auris infections. So now that I've scared you all, and reminded you about the importance of CRBSI prevention, I want to talk a little bit about things that we're currently doing now. It's hard to believe, but it's been 15 years since the IHI, the Institute for Healthcare Initiatives, came out with their Save 5 Million Lives campaign. And they're the ones that first came up with those 5 things that we should do that are now very well accepted as our central line insertion bundle. Avoiding the use of femoral sites, getting femoral lines out as soon as possible, maximum barrier precautions, hand washing, use of chlorhexidine and to prep sites before insertion, daily review of line necessity. Those things are pretty ingrained in everybody's practice at this point. So what are some of the other things that we have started to do? Well, there's been a renewed focus on hand washing and scrubbing the hubs of our IV catheters. A lot of education surrounding that. We've also employed some chlorhexidine-based products, dressings that help prevent germs from getting into the IV site. The use of maximum barrier precautions, sterile techniques, and ultrasound for first attempt success, and the use of impregnated catheters. These are all fairly common in hospitals today. Let's talk about some new approaches. Probably one of the most recent things that we have been implementing in every hospital across the United States is the resurgence of midline catheters. There's been a pendulum swing. For a while, we went away from using midline catheters, and part of that was due to the confusion between a midline and a PICC. Midlines would be used inappropriately for central medications that needed to be given to central circulation. And because of the concerns surrounding them and some of the complications, hospitals went away from using them. They have come back into vogue, so to speak. And some of the reasons for that are some of the new insertion techniques for midline catheters. We now have all-in-one devices and accelerated Seldinger technique. We've made midline catheters power injectable. So now you can get a midline that can be used in CAT scan and MRI for power injection of contrast. That didn't always exist. So that made them more utilitarian. We're also constantly looking for alternatives to central venous catheters and PICC lines. Because if you don't have a central venous catheter, you can't get a central venous catheter infection, correct? Sometimes that is the appropriate way to prevent an infection. However, sometimes it's not. And sometimes you really need a central catheter. So we need our vascular access specialists to really be in control of deciding what type of catheter the patient needs to successfully complete their therapy with the least amount and the least risk of complications. We've also seen an increased use of peripheral IVs. And part of that is driven by the fact that very many hospitals have gone to clinically indicated changes for peripheral IVs. Did you know that the first time the length of dwell time was removed from the INS standards was 2011? A lot of people don't realize that it's been 9 years since the dwell time limits have been removed for catheters. Not every hospital has gone to clinically indicated changes for peripheral IVs, but many, many have. And there's quite a bit published now in support of that, showing that there's really no higher risk in leaving catheters in until they fail. But the key to you doing peripherally indicated peripheral IV changes is education. Your staff has to understand what clinically indicated really means, what a bad IV looks like, feels like, how it works, how it responds. In fact, I have a little story to share. I was doing a point prevalence in a hospital. I am very honored to be able to travel the country and visit many hospitals and learn what their practices are and help them be successful in avoiding infections and other complications. So I was rounding and checked on a PICC line on a patient and noticed they had a peripheral IV lower in the arm, in the same arm as the PICC line. But it was blocked off, closed off, not used. But the site itself was red, and you could tell it was a bit swollen. So I asked the nurse, was she aware that the patient also had a peripheral IV lower in the forearm toward the wrist? And she said, oh yes, definitely. So after we left the patient's room, I asked her, I said, can you explain to me why the patient still has a peripheral IV that isn't being used when they have a PICC line in the same arm? And she very seriously responded to me, oh, because we only change the peripheral IVs when clinically indicated. So I said, okay, makes sense to me, that's great. So can you explain to me, I asked her, what is clinically indicated for you guys? How do you decide that? And she replied, well, it's when the doctor orders it. Oops. I was very surprised to hear that because I think we all realize that a doctor is not going to order a peripheral IV to be removed. They probably don't even realize their patients still have the peripheral IV in place once the PICC line is placed. So just to remind everybody that peripherally indicated, clinically indicated changes for peripheral IVs is excellent for your patient, but you want to make sure that your staff understands exactly what that means. We've also seen an emergence of impregnated PICCs and midlines. And these PICCs and midlines are now impregnated with antimicrobials or antiseptic treatments. And this is fantastic because now you have another treated catheter that you can use in your arsenal, especially if your patient is suspected of having a central line infection. They're great to use for patients in the rule out infection category, or other high-risk patients, such as burn patients or oncology patients who are at high risk. These are some of the handouts that are available on the CDC website. Another new thing that we've been doing is educating our patients. It used to be that we would go into the patient's room, do the tasks we need to do, and be on our way. Now we have to involve the patients in their care. In fact, it's one of the Joint Commission standards is that patients need to understand the risks of having a central venous catheter. So handouts such as this one from the CDC are excellent for that, purpose. This one is actually even endorsed by APIC. You'll see clean hands posters all over the hospital, reminding not only healthcare providers, but patients and visitors to wash their hands frequently because clean hands are safe hands. These tools to help educate your patients and allow the patients and the caregivers to take ownership of their line is very important to preventing CLABSI. We're all human. We all make mistakes. There are always lapses in habits. And so we shouldn't be offended or put off if a patient asks us to please wash our hands or reminds us to use an alcohol wipe before they enter our central venous catheter. I think the more we encourage patients to take ownership in that way of their health care, the better off the hospital will be, and certainly the better off the patients will be. Hey, Judy, time for a totem pole.
I love a totem pole. Here it comes. So, does your facility use alcohol caps? Yes on all lines, only on central lines, or no? And we're finding 44% put them on all lines. And then it's split 28%, 28% on central lines only, or no, they don't use them.
That's fantastic information. Thanks everybody for sharing that. I ask because alcohol caps are one of the new approaches that we have to preventing infection. And as reflected in the poll, it seems like many hospitals have adopted them. And they are fantastic when used with certain types of needleless connectors. However, they're not inexpensive. So that's something to be aware of. And they're only good for one-time use. They can't be reused. They don't eliminate swabbing completely. When you take off an alcohol cap, after you do that initial flush, you then still need to scrub the hub with an alcohol wipe before you connect up your IV medication. And then after you disconnect your medication, you should scrub that hub again with alcohol before you attach your flush. And then you can replace a new alcohol cap on before you walk away from the patient. Compliance with using alcohol caps is an ongoing challenge. And this is really why some hospitals have found that their alcohol caps are not as effective as they thought they would be. This type of alcohol cap with the pad inside of it has been replaced for one of these companies with a dam, so to speak, that when you attach the alcohol cap, it bathes the connector in alcohol. One time, kind of whoosh. This one still has, some of the other ones still have that white alcohol sponge, so to speak, at the top of it. But what the alcohol caps don't do is they don't address the threads at all. So that's one reason that you need to use some friction to really clean the septum and the threads, and in between each access, each and every access. There's also been some reports of the alcohol caps not being very effective when they're not used on all lines across a hospital. So if you're in one of those, that 20% of hospitals that are only using it on central lines, but your patients still have peripheral IVs as well, or midlines, that are not getting the alcohol caps, and you're not seeing zero, that might be part of the reason why. Compliance is a challenge with these. You have to keep reminding nurses to keep using them. When they first hit the hospital, everybody's excited about them and they want to use them. And then as time goes by, we revert to our old habits. It's human nature, unfortunately. As I stated, these alcohol caps are not inexpensive. They range anywhere from as high as 40, 45 cents each to about 20 cents, as compared to a plain alcohol pad, which is about 1 cent. And the CHD alcohol wipes they run about 10 cents. So if you add it up over time when you're replacing those caps all day long, it can get kind of pricey. So we've looked at a lot of different options, a lot of different things that you guys might be doing to prevent infections now. But I wonder, have you looked at your needleless connector? All of the interventions that we've seen focus really on the outside of the catheter, the insertion of the catheter itself, treated or non-treated. But nothing really focuses on the intraluminal pathway or the entryway to your patient. Pictured here are some of the devices that are currently on the market. The ones across the top row here that you see, these are all considered neutral, or they're marketed as neutral connectors. These down here on the right-hand side are still available, and these are negative displacement connectors. So what a negative displacement connector does is, now this only applies to connection and disconnection from a syringe, but just to clarify, a negative displacement connector will draw blood back into the back of the catheter when you disconnect your syringe. These three here on the left-hand side are all positive displacement connectors. And so what these do is when you disconnect your syringe, they will give a little positive bolus of saline hopefully out the back of the catheter. Hopefully it's enough to push all the blood back out of the catheter. And what's important with these that are positive is that you don't clamp the catheter until after it gives itself that little bolus. So you definitely do not want to clamp your catheter when you have a positive displacement device until after it gives that bolus. Hey, Judy, how about another poll?
What type of needleless connector do you use at your facility? Okay, I'm going to close this poll and share with you. Positive displacement at 30%, neutral 44%, 7% at negative, 9% no idea, and 10% use more than one type.
That's really interesting. I find in a lot of hospitals when I'm traveling across the country that the hospitals do use more than one type of needleless connector in their facility. Some are department specific, some are specific. They use one type for central lines, one type for peripheral IVs. Sometimes it is a matter of we're using up the old stuff before we use the new stuff. And because of that, a mix of different connectors come into play. That is interesting, but it does create confusion in a hospital. If there's more than one type of connector, especially if clamping sequence is important, as it is with positive and negative, it can cause some confusion, and that confusion can actually raise your occlusion rates. And we know that occlusion rates are tied to infection rates. So that's something to think about. So a little bit more about needleless connectors. Let's see what Dr. Jarvis has to say. Dr. William Jarvis was employed by the CDC for more than 20 years. He's got more than 400 publications in peer-reviewed journals, and he is one of the foremost experts on infectious diseases and epidemiology. He wrote an article in Infection Control Today and to say what his ideal needleless connector would be. And I share this with you because I want you to take a look at the needleless connector that you're using in your hospital and see how many of these benefits or features that it checks off. Does it have a smooth septum surface? His ideal connector would have a tight seal between the septum and the housing. There would be a straight fluid pathway, so it's easy to flush, no places for germs or blood to hide. It would have little to no dead space, because the more dead space you have, the higher amount of reflux you have, and also the higher risk of biofilm formation. It would have a direct fluid pathway with no moving parts. It shouldn't require a clamping sequence, which would eliminate the clamping sequence confusion. It It should be transparent so you can see whether or not you've flushed it completely. It should, of course, be luer access with little to no blood reflux into the catheter on connection or disconnection. And it should be able to be flushed with normal saline only. We've really moved away from using heparin in the hospitals and really across the United States in many care settings. And one of the reasons for that is heparin has not proven to be any better in keeping catheters patent than normal saline alone. And also heparin is tied to some complications such as biofilm formation, growth of microbes, and also heparin-induced thrombocytopenia. So what is new with preventing CLABSI? Well, to me, the biggest new thing is something that's been around since 1954, believe it or not, chlorhexidine. Chlorhexidine is one of the keys to preventing central line infections in many different ways. I don't know if you know how chlorhexidine works. I found it to be very interesting myself, so let me share it with you. Chlorhexidine is a positively charged ion, and it forms an ionic bond to the cell walls of the bacteria, of viruses, of fungus, and it actually tears those cell walls apart, trying to get in and rupture the internal membranes of these cells as well. So the positively charged chlorhexidine binds to the cell wall and causes that cell membrane to rupture, causing cell death. It also has the bonus of inhibiting some biofilm formation because it inhibits the adherence of microbes to a surface. It prevents them from sticking to things like silicones and polyurethanes. Chlorhexidine, like I said, has been around since 1954. It's not new, but it's unique as an antiseptic. It's not affected at all in the presence of fluids, blood, other body fluids, and it actually binds to human tissue. That's what allows it to have the residual that can last at least 48 hours. It's been proven that daily chlorhexidine bathing in the intensive care units can reduce all sorts of infection risks. It reduces all of the hospital-acquired infections that we talked about earlier. Ventilator-acquired pneumonia, surgical site infections, and of course, CLABSIs as well. It works so well that, and because it comes in different forms, it can be impregnated into different medical devices. It's very common in dental devices and oral use because it binds very easily to your oral mucosa. It's used in implants. It's used in vascular catheters. And it's also used in dressings. In fact, there has been a chlorhexidine impregnated central venous catheter on the market since 1992. If you use a blue central venous catheter, that is an antimicrobial catheter that has chlorhexidine impregnated into it. So it is very excellent to use and for your patients, especially those at risk for central line infections. But now it's also impregnated in a needleless connector. The wonderful thing about chlorhexidine is it kills all organisms, viruses, bacteria, even resistant bacteria. And so far, we have not developed any bacteria that are resistant to chlorhexidine, despite its use since the 1950s. Judy, I guess it's time for another poll.
What do you use to clean your needleless connector? Isopropyl alcohol, chlorhexidine glutamate, and 70% isopropyl, or other?
Yeah, I put other in there in case you guys use one of those scrubbers. They're only alcohol, but you might think of it as different than just an alcohol pad or a wipe.
Thanks for that clarification, Chris. Okay, let's find out what people said. So we have 74% that use 70% or 70% isopropyl alcohol. 24, so a quarter use chlorhexidine and isopropyl, and the 2% are in the other category.
Okay, so most of you are using regular alcohol wipes. And I think that's great. It's very effective and very cost effective as well. Speaking of costs, let's do a little bit of a cost analysis. I did mention that there is a chlorhexidine and silver impregnated needleless connector available on the market. And I'm sure you're thinking, gee, Chris, that's great. Yeah, it does work 24/7, but it is more expensive. Absolutely. And I'm sure you guessed that already. So, but let's take a second here and compare the cost of using a non-treated connector and an alcohol cap compared to using a chlorhexidine treated needleless connector and a regular 1-cent alcohol wipe. If you're making some assumptions here that the average patient has a double lumen catheter and you're accessing that catheter about 8 times a day, like a typical ICU patient, if you add up the cost of your connector with your alcohol cap, you're spending about $2 a day on that patient. That's using a 96-hour connector change. With a treated connector, you can go to a 7-day connector change, and you no longer need the cost of the alcohol cap. So now your daily spend for that patient is down to only 65 cents. This can generate a cost savings of 43%, ranging from somewhere $117,000 a year down to only about $21,000 a year. So if your hospital is concerned about saving money, as all of them are, something you might want to consider. Well, gee, Chris, that's great, you're thinking, but does it work? So you don't have to take my word for it, and I wouldn't expect that you do. I want you to do your own research. So let me give you some opinions from some of the people that use it. This is a hospital that converted, and once their conversion was complete, they went 7 months without one CLABSI. Here's another hospital, a little bit bigger, 800-bed level 2 trauma center, used to use alcohol caps on their connectors, but they weren't getting the rates that they expected. They didn't see the drop in CLABSI. So they switched to a needleless connector with chlorhexidine silver for all lines, central and peripheral. And not only did they see a 41% drop in their CLABSIs, one ICU dropped 70%, but they also saw a TPA usage drop 47%. They saved their hospital over $500,000. This was a poster that was presented at APIC in 2018. That same hospital now, as of March, they have one unit that's gone more than 2 years, 1,062 days without a CLABSI at 0. One of their ICUs has gone more than a year, 411 days. Their oncology unit has gone 400 days CLABSI free. 2 of their medical units, 144 days. And their CIC, which is a coronary unit, went 175 days CLABSI free. So is 0 possible? Yes. It really is, even in the days of COVID-19. Is it an easy fix? No, it's not. And Sophie Harnage and her team at Sutter Health Roseville proved that 0 is possible. They went 7 years with 0. They went 10 years with 1 CLABSI, over 20,000 PICC lines. So is it possible? Absolutely. But if you take a look at her bundle, she truly used a bundle. It was not only products, it was also people. It was practices. They literally took ownership of every line in that facility. And they were able to do it with implementing the right products for their patient population, and really policing and taking ownership of their central lines. So is it possible? Yes. And this is your call to action. I certainly hope that when you can focus on something other than COVID-19, which will be soon, very soon, I hope, you'll be able to take another look at your CLABSIs in your hospital. If you don't have a central line prevention committee in your hospital, see if you can champion one and get one set up, because it takes a village, takes a team to do this. Take a look at your processes, take a look at your products, take a look at your people, and you can fight the good fight and get to zero. I want to thank you all very much for your time this afternoon. It was an excellent period of time, and I appreciate, I know that you're all very busy. You can certainly reach out to me at any time. I'm happy to answer any questions that you might have today, or if you think of something tomorrow or next week, please reach out to me.
Thanks so much, Chris. I appreciate this. And I want to make sure that I do thank our sponsor for today, which is RIMED Technologies, for sponsoring our webinar today and for Chris speaking. We do have questions already for you, Chris. So first question we have is, should we blood culture everyone coming into the hospital with central line?
That is not a current recommendation. The idea is the hospital only has to report central line infections when they Hi, Judy.
Always come.
It's awesome. The hospital reports central lines after the second day that they've been accessed. So if there are signs and symptoms of a central line infection, then do your normal central line infection workup. But everybody should not be cultured across the board. It's very costly to run blood cultures and not necessary for every single person.
Thanks. How do you feel about CHD Silver impregnated needleless connectors?
Well, I think a treated antimicrobial needleless connector can really show great outcomes if your hospital has already tried a lot of other interventions to help reduce CLABSI. A lot of times we focus on the dressing, or we focus on the catheter itself, we focus on the skin, but we tend to forget that the entryway to the body is really the needleless connector. That's the doorkeeper to the gatekeeper to the interluminal pathway. So having a needleless connector that's treated with chlorhexidine and silver can certainly augment your CLABSI reduction strategy. And although it does need to be cleaned prior to every access, just like every other needleless connector, it does help protect the patient 24/7, similar to what an alcohol cap does, without the need to add an alcohol cap.
Thanks. And you're right. There's every aspect of vascular access that has to be considered when we're looking at CLABSI protection. We can't, put all our focus into the dressing and forget insertion and the fluid pathway. Okay, another question for you. Is there any problem with connectors or IV tubing breaking down and causing connections to bind like glue?
Not that I'm aware of. What we found anecdotally is that the CHG wipes that are wet, if they're not given enough time to dry prior to connections, then it could cause the plastics to stick together. CHG in the drying process gets sticky if you don't let it dry completely. So if you're going to use those CHG wipes on any of the connectors, then you really need to let it dry the entire time before you connect any tubing to it. That helps with preventing the stickiness. And now the impregnated needleless connectors that have the CHG impregnated into the septum, that is not an issue because the CHG isn't wet and there's no dry time there.
I think it's also true with just even the alcohol plagettes. If you're cleaning that connector and you don't let the alcohol dry completely, that actually creates a bind between the plastics as well. So there's
Yes, you're absolutely right. It does.
a question from our next guest. I used to work for a facility that used Clorox wipes for connection disinfection. We were taught to scrub for 5 seconds. Is there any evidence to suggest otherwise?
Well, I don't believe that there's any evidence to suggest using a Clorox wipe is a good practice for cleaning needleless connectors. The INS recommendations state pretty clearly to use either isopropyl alcohol or a CHD IPA wipe. There's no recommendations for using anything that's not one of those two. So I don't recommend use, and I don't believe that the Clorox wipes are actually been tested against using needleless connectors. So I would be cautious in using that instead of alcohol or a chlorhexidine alcohol wipe.
Yeah, so would I. Great answer, Chris. Thanks. Should we not follow the IFU for the manufactured caps, which say there's no need to scrub after the cap has been removed?
Well, that's a difficult challenge because the problem with the alcohol caps is that the alcohol itself only impacts the top of the connector. So if the cap has a sponge in it, then it only impacts the septum. There's nothing to clean the threads. There is a type of alcohol cap that gives a little burst of alcohol that might bathe the threads a little bit. But the challenge is, if you read the INS standards or even the AVA resource guide, it does say to vigorously scrub. And putting a cap on is a passive disinfection. There's no vigorous scrub, so there's no friction there. It's kind of like the equivalent of using mouthwash instead of brushing your teeth. You can use mouthwash to augment brushing your teeth, but you still need the brushing to get the germs and the biofilm that starts immediately to come off your teeth. You kind of need the same thing for the threads of the needleless connector and even the septum. There is a need for that vigorous scrub, that friction to clean and to get the germs off of the threads especially, but also the septum of the needleless connector. And then the other important point is once you take that alcohol cap off, even if you don't scrub that very first connection to flush, you absolutely need to scrub before you connect your drug to infuse or your IV push. And then you need to scrub again with an alcohol wipe before your final flush. And then you can put on another cap. So don't skip the 2 steps in between the 2 caps.
That's a great analogy, Chris. I love the brushing your teeth on that. And my other point to this is, what would you do if it was your loved one? And that's the way I want to practice on everyone. If it was my loved one, I would always scrub the hub, always.
Exactly. That's a great way to look at it.
Well, Chris, thank you so much. We have many more questions, and I realize time is very important for a lot of our attendees, but we will get to all these questions. If you have any interest in seeing the answers to these, we do have a list of those, and you can always contact ava@avainfo.org, and we can get you some more answers. Thank you so much. Have a great day.